This conference will now be recorded.
Hello, am I audible?
Yes, ma'am.
Okay. Today we are going to discuss about the topic developmental dysplasia of the hip. This is otherwise known as congenital dysplasia of hip also. Recently it's known as developmental dysplasia. Coming to the normal development of the hip of humans, in 7th week, acetabulum and hip are formed from same mesenchymal cells. And in 11th week, there is separation between the two. That is, acetabulum differentiates and femoral head differentiates. And proximal ossification completes by 4 to 7 months. This is the normal hip. Here you can notice that the hip is well located into the acetabulum cup. This is known as tight fit of head into the acetabulum. What is the definition of developmental dysplasia of hip is? It is a spectrum of disorders of development of hip that presents in different forms. That is, the hip may be dislocated, dislocatable, or subluxated. The different terms we will be dealing in the next slide. Coming to the epidemiology of the condition, the common etiology is laxity of hip capsule. Although the common etiology is still unsure, this is just a hypothesis that is hip capsule is lax, which leads to failure of maintenance of the femoral head in the acetabulum. Strangely, this condition is more common in females. That is, 80% of the affected people are females. 1 in 1,000 live births and 10 in 10,000 births with subluxated or dysplastic hips. As I told you, the different terms dislocated, dislocatable, and subluxatable. These are the different terms used to define the DDH. Dislocated. This is the severe form of DDH where the head of the femur is completely out of the socket. Dislocatable. In this case, the head of the femur lies within the acetabulum, but it can easily be pushed out of the socket during the physical examination. Okay. Subluxatable. This is the mild form of DDH where the head of the femur is simply loose in the socket. It keeps moving in and out from the socket. This picture shows the different types of DDH. The first picture is the normal, second is subluxated. You can notice that part of the femoral head is in the acetabulum and part of it is out of the acetabulum. This is called subluxation. Third form is dislocation. Dislocation is completely, it is out of the acetabulum. The causes, as I already discussed, the cause is pretty unclear. The common hypothesis is the family history. When one in the family is affected, the others in the family or the progeny of that person can also be affected. That has not been yet proved, but that is one hypothesis. And gender. 8 in 10 cases of DDH patients are females. Pregnancy conditions, oligohydramnios tend to increase the incidence of DDH. And it is known that first-born babies are more common with DDH. Any congenital abnormality is more common in the first-born child. Mostly DDH babies are more associated with other abnormalities like cerebral palsy, spinal cord syndrome problems, and other nerve and muscle disorders. Breech position is one position which increases the incidence of DDH in the babies. Symptoms. This is the picture depicting the symptoms of DDH. As you can see, there is a limb discrepancies. The right lower limb of the baby is little shorter than the left, and there is a like asymmetrical gluteal fold and excessive folds over the right thigh. This is depicting feature of DDH when the baby can't walk, when the baby is still a neonate. This is how you differentiate from the normal. Different limb lengths, no outward signs, uneven skin folds, less mobility or flexibility on the affected side. When the baby is walking, they would tend to walk with a limp or toe walking or waddling. This type of gait depends upon the intensity and severity of the DDH, duck-like walk. Okay. How do you diagnose this DDH in a neonate? This is a general protocol to screen every newborn baby for DDH. The different tests and manuals to identify a neonate with the DDH. These are Ottolin's test and Barlow's test. These are the commonly done tests. How do you do this test? I'll tell you. This is Ottolin's manual. Keep the baby safe on a couch and tend to. This is the first picture there where there is a already dislocated hip. In second, You're relocating the dislocated hip. That is Ortlin's maneuver. Hold the baby over the thigh near the knee and tend to put the downward pressure. You can see downward pressure, downward directing arrows, and tend to put the downward pressure and abduct it so that it will be relocated. You will hear a clicking sound if the femoral head is relocated. This is positive Ortlin's maneuver. This is a Barlow's maneuver. This is reverse of Ortlin's maneuver. In Barlow's maneuver, you're dislocating the hip. In A position, you've got opposite of Ortlin's, that is outward pressure and abduction. Then you're dislocating the normal hip. This is the clinical test you need to do on every newborn baby to identify DDH. And the other thing, as we already discussed, there are many associated abnormalities with DDH. You will have to perform head-to-toe examination to rule out any cerebral palsy, torticollis, or other ligamentous laxity, like dislocatable shoulders and all. Neurological and spine examination. These babies are generally combined with spina bifida and all. So you need to rule out all those conditions. So you need to perform head-to-toe examination, spine and neurological examination. Key physical findings are limb-length discrepancy. Limb-length discrepancy can be identified by Gallagher's test. The second picture depicts the Gallagher's test. You see this abnormal, here you can see abnormal levels of knee joints. This is positive Gallagher's test. Ask the baby to flex the hip joint and knee joint and check for the symmetry of the knee joint lines. This is Gallagher's test. And abduction for the range of movements, and skin fold. Already discussed skin fold. If the baby is walking, look for the limp or waddling gait. In bilateral involvement, you will see hyperlordosis. After physical examination, you need to confirm your diagnosis. Confirmation of diagnosis can be done with different diagnostic methods, that is X-rays, ultrasound, CT, MRI, and arthrogram. Ultrasound is the most gold standard for diagnosis of DDH because in the children in neonates up to 6 months, you can't visualize the femoral head in the X-rays. That is, ultrasound is the most important investigation. But the negative part of ultrasound is that it is an operator dependent. So, coming to X-ray, these are the two lines. This is known as the vertical line is known as Perkins line, and the horizontal line is known as Pilgrim's line. Usually, the femoral head falls in the inner quadrant of bisecting these lines. But in dislocated hip, you can see that this has moved outwards. This is one feature which differentiates it from the normal hip. The other one is the Shenton's line. Shenton's line is the line continuous from the inner border of the femoral head, neck, and the outer rim of the acetabulum. If this line is broken, you can say that if there is something wrong with the femoral neck or head. In DDH, you can see Shenton's line is broken. This is the Shenton's line. This is broken. And the femoral head in the upper and outer quadrant of the lines bisecting this Perkins and Hilligren's line. CT is absolute, but that is not highly indicated in neonates because it causes more of radiation. And orthogram, this is done for the open versus closed reduction to check whether already the joint is reduced or not. So the gold standard of imaging is ultrasound and X-rays. This flowchart says the timing and the decision making in treatment of DDH. See, if the baby, if seen that is subluxating, and observe for 3 weeks. If it's stable, you need not intervene. If it is subluxating even after 3 weeks, proceed with the Pavlik harness. This is the Pavlik harness. Baby is kept in the abduction and maintained with this harness. Even in the Pavlik harness, there is subluxation. Then check for the neuromuscular examination. This is the section of subluxation. This is a mild variety of DDH. Coming to DDH in the severe variety, that is like dislocatable form. If it's non-reducible, then check for something is wrong with the muscular problems. If it's not reducing, then you will have to go for the open reduction. If it's reducible, continuous with the Pavlik harness. If it is reduced, wear it for 3 months, then wean regularly and maintain with the abduction brace. Not reduced at the end of 2 weeks, reevaluate, then perform closed or open reduction. The basic theme of this flowchart is that you will have to divide the hip into subluxated or dislocated forms. Subluxated, observe for 3 weeks. If it is stable, no treatment. At the end of 3 weeks, if it is subluxating, go on with Pavlik harness. Dislocatable hips, non-reducible hips, right away go with operative treatment. Reducible hips, go with Pavlik harness. And they are not maintaining the reduction, again closed or open reduction. This is the picture taken from the pediatric textbook. How to maintain and how to treat the DDH in different age groups. In neonates, that is from 1 month to 6 months, place the patient in Pavlik harness. This is the gold standard of treatment. This has to be started very early in age, that is at age of 1 to 6 months. 6 to 8 months, try closed reduction. If it is not successful, then attempt for the open reduction. Open reduction is something you cut open the joint, place the femoral head back in the acetabulum, and stitch out the structures. It can be done via anterolateral approach. In 18 to 24 months, closed reduction can be tried, but a closed reduction is not generally possible in 18 to 24 months. You'll have to proceed with open reduction. If it is necessary, you'll have to perform an osteotomy, that you have to cut through the bones of femoral head and place back in the position. From 24 to 6 years, the primary treatment is open reduction and femoral shortening with or without saltus osteotomy. This is the Pavlik harness. This is spica, hip spica. This is another way. These days we are not doing this. Von Rosen splint. This is the next stage when the baby has crossed the 6 months, when Pavlik harness is already done. This Von Rosen splint is done is applied to maintain the abduction. Here you can see that 3 thongs, one at the thoracic level, one at the shoulder level, one at the thigh level. This maintains the abduction of the hip joint. Surgical treatment. If the baby is not maintaining the reduction in spite of all those splints and all those spicas, then you'll have to you'll have to go on with the surgical management. The main theme of surgical management is open reduction. If you fail to do the closed reduction in 2 attempts, you'll have to proceed with the surgical management, that is open reduction. Then you'll have to do the osteotomies either on the acetabulum side or femoral side to maintain the reduction of the hip joint. This is the basic outline of DDH and treatment. And does anyone has any doubts?
Ma'am, what is Pavlik harness?
Yeah. Okay. This is the type of brace. Pavlik harness is a type of brace which is used to maintain the abduction. This has 2 wings here. In one wing you are placing the foot, and the other it is the shoulder straps. You'll have to maintain the abduction which is equivalent to the length of the shoulders. This length has to be maintained here. This to maintain the reduction of the hip joints. Is that clear?
Yes, ma'am.
Yeah. Anything else? Okay, coming to the outline of DDH, this is more common in females. The cause is unclear, oligohydramnios, family history, genetic mutations. These are the common hypothesized causes. Every newborn has to be screened for the DDH. The 2 clinical examination techniques are outlines in Barlow's method. I have already told you. Are the tests clear for you? Okay. Atlas and Barlow's are 2 tests. Then for confirming the diagnosis, you'll have to proceed with X-ray, ultrasound, and treatment options. Up to 6 months, you'll have to maintain the kid in the Pavlik harness, and later Von Rosen splint, open or close reduction, and osteotomies. Anyone has any doubts? Okay, then we're closing the session now.
This conference will now be recorded.